So if you can still hear me and see me, I'm quite happy to answer any questions about anything. There's no such thing as a dumb question. Did that make some sense? And who wants to go first?
Thank you very much, Dr. Rawson. Good night.
Okay. You're on your way? Okay, thank you.
Thank you.
Lori, you're always good for a question too, Lori.
Yes, I would have a couple of questions.
Okay.
Question number one is, how is the reception of a patient who has a short upper lip?
Right. Okay.
Go
Yes.
on. So how does that go up with a 10 millimeter opening in the vertical?
That's a very good question. And initially, that's always a problem. They complain of drooling because they don't have lip competence. But generally, counter to that is they will tell you, here's what I learned about doing chronic pain for the last 20 years. Patients are always going to throw the negative at you first, and you have to search for the positive. So I sit and listen very patiently about, oh yeah, you drew, okay, yeah, your lips are cracked. But tell me about your sleep. Oh man, I was dreaming. I felt great. I got out of bed. I went to work. I felt great. Oh, okay, fine. So you have to be prepared for the negative. We work with our patients a lot with nasal breathing. And when I'm comfortable that they are in a good place, I'll suggest lip taping. You can send them home with a roll of medical grade surgical tape and have them hold their lips together with tape. And if in the morning the tape's still on there and the appliance is still in their mouth and they're still alive, you fix them. It's as simple as that. But if you had a very small patient, very short lip, perhaps an extraction case, you need to tell them in advance, this is going to be much higher than anything you've ever worn before. But you're here because you have a medical problem called not breathing, and you probably are here because you either declined your CPAP or you don't wear it, or it's under the bed and you're exhausted. Now, I take a lot of time to connect a lot of dots about chronic pain and make them understand that fibromyalgia is only a syndrome, just like chronic fatigue is only a syndrome. If I can get rid of that and make you feel a lot better, are you okay with, a little bit of drool for a short while? But that would be a concern, but it's never stopped me from treating patients, Lori, but that's an excellent question. You had another one there.
I sure do.
Lori?
Second question is,
Fire on.
the second question is, are you selective
You
of
just
the
cut out
patients
there.
with,
Try it again.
are you selective of your patients
Says my
who,
internet connect.
I'm not muted. Can you hear me?
You're breaking. No, okay. Try it again. Am I selective of my patients? And I just heard ping, ping, ping.
Yes. Are you selective of your
Are you still-
patients when they have neck injuries or difficulty in neck rotation, because the vertical is going to definitely stretch at 10 millimeters, even though you're only opening them anteriorly 2 millimeters or 3 millimeters? You're going to be stretching the stylomandibular ligaments, getting yourself into
you're fading off, but I think I got the essence of your question. Can everybody else hear me clearly?
Yes. Yep.
Trouble. Okay. All right. Well, if you'd asked me this question 15 years ago when I was just getting into it, I would probably say yes. But here's the deal. We're fairly well known in Southwestern Ontario. We see all kinds of patients that have had all kinds of injuries for many, many years. And I simply offer the service of providing a better airway to let their body heal to the best of its ability, given that they're being treated by lots of other folks. And while it's a concern, the question to myself is, you presented here, you either referred or you found me on your own. You're clearly not breathing well. Let's see if we can help you with that. And it's amazing. It's amazing how much better people do when you give them that drug called oxygen. I might in this particular case be a little more careful on my vertical, but no, I've never turned down. Well, the only people that we have some concerns about are poor dental patients. Are you missing a lot of teeth? Do you have full dentures? What's the perio like? Do you actually have a dentist? Can I trust that you go to your dentist regularly? I don't even have an intraoral radiograph machine, so my evaluation is range of motion, walk around the room, a panoramic film, so I know kind of what's going on. But if I was concerned about perio, or if there's ongoing dental treatment, of course we cannot. We have to work together with the GP office. But in terms of bodies that have been damaged and abused and neglected and overlooked for years, bring them on. They'll get better. And here's the deal. The kind of work we do is so rewarding because I've still not done this, but in my head, I want to put a picture on the wall of a dried up old plant that you're going to throw out and put beside it the one you brought home from a flower shop. We think of our patients as those dried up, wilted flowers that you're ready to throw out, and then we give them their life, and they just take off like rockets. The human body has the potential to heal itself. All I do as a dentist is give it that drug called oxygen and put their jaw in a healthy place. And other than the dental concerns, I probably would not turn that patient down, given that they sought our care because they are not breathing well. Does that make sense, Lori?
Thank you, it does.
And I don't want to come across as cavalier, but you need to know, folks, I got into this whole field by having an outside interest in orthodontics many years ago, which led me to a realization that the teeth are connected to a thing called the mandible, which hinges in a thing called the jaw, which I didn't learn in school. And as I jumped into that deep pool, I found out, oh my God, this is connected airway. So it's been a gradual process for me, but this is all I do. And again, we get to work with some pretty damaged systems, but some very grateful patients. So as long as they have decent teeth and I can be comfortable with that, I simply tell them, look, at the job of me taking off a CPAP and putting in oral appliance is much, much harder. All you need for CPAP are 4 holes, 2 right here, your nose, and 2 in the wall, which is a plug. And you just put this thing on. And if it's still on in the morning, it probably worked. For me to make an oral appliance, I need to put not 1, but 2 hockey pucks in your mouth and have it stay there all night. And you wake up feeling great. And I talk that way, but then I deliver. And when I deliver, more patients come. My biggest frustration is breaking into the medical world. Don't get me started, but I'm on the sleep rounds at our local hospital. I present there regularly. I go to every meeting. They know what we can do. They just think CPAP is the only way to go. So I'll be long gone from this earth before we'll all be able to consider it equally. So just one patient at a time. Do the best job you can, and you'll get others coming on their own.
I have a question.
Paul, of course.
What was your route to coming up with such a wide opening? You didn't start out that way. What got you there?
Well, the phonetic bite technique is what we learned in TMD work all along. And so it was a natural progression to go, well, if I'm opening the bite by this much for resetting the jaw, and then it turns out it actually improves the airway, well, why not just take it to its maximum limits, knowing that I can reduce it by 1 millimeter or 2 or 3 if I have to. And so it just kind of fit. And then I said to myself, well, here I am now. I'm the founder and president of this Canadian-wide organization called Clinical Sleep Disorders. And I'm hiring all these medical specialists to come and speak to us. And I'm doing this. I better prove this works. So I took it upon myself to actually see if it works as well as I thought. And so what you saw tonight was a 90-minute lecture I presented to my own meeting, validated by all the testing that most people do. And it works. But if you told me 20 years ago, you're going to open the bite 10 millimeters and everybody's going to do well, I'd be scared because I'm a doctor of subtraction. I learned how to take a high-speed rotor and cut cuffs off and close bites down because that's what people need. Well, I just the opposite. So,
do you consider the Shimbashi measurement at all when you look at how big they're open?
I used to, but I presented 3 cases tonight that showed you 100% overbite, a normal occlusion, and end on. And I chose those all on purpose because I wanted to show 3 different kinds of presentations that each and every one of us will see in our offices every day. And I chose them because I guess I probably initially wondered, will this work? And guess what? It did. The very first video I showed where I'm standing in the room with my little gown on and the mandible, the skull in my hands, the message I was trying to get across to you audience, and I remind myself, but most importantly, say to the patients, look, I'm the doctor, I get it. I have a great staff, I get it, but I don't have the answer. I want your brain to tell me where to start. And let's just do this number thing. And so when you accept that you don't have to know the answers, you just have to be able to ask the questions and then take the answers and work with it and then prove it. So I proved on a small scale, 34 cases, not 10,000, but consistently we had a 75% reduction. That's amazing. So good teeth, fairly decent jaw, a willingness for patients to say, I'll work with you. And I don't think I've ever had anyone come back and hand it back in. I've never had anybody say, I don't like this. I've never had anybody say, give me back my money, I want to go on CPAP. My biggest problem is they don't come back because it works so well. I can't prove sometimes that I want to get a test to prove it. Hey, it's worked great, doc, it's fine. You don't know how many couples cannot sleep together. You don't know how many times I say to guys, winter's coming, let's keep you out of the garage. Let's keep you healthy. And just today we had a couple in and I said, I'm also in the marriage enrichment business. And the lady rolled her eyes and said, how did you know I was going to tell you that? Turns out these are musicians who travel on, no longer, but used to be onboard musicians on cruise liners. She said, you'll have no idea how tough it is to spend a night with this guy in the smallest cabin that we staff get. So it's a societal problem. You can do it. Stop thinking it. Just follow these rules. Now, I'll make this commitment to anybody who wants to do it by sending me an email. When I gave this talk in our meeting in Toronto, when I've given it to study clubs in the province and I've been all around, I will make up a package called the Phonetic Bite Technique. It'll be a Ziploc bag with a set of instructions, a sample of all the round suction tubes you need. I probably even put in the syringe of Quick Bite. I won't give you a gun because everybody's got one. And just say, look, do it. Practice it on your staff. Practice it on your family member. It's not that hard. You don't need to buy anything. You got it in your office. The most important thing I tell colleagues when they want to follow me, I say, look, give yourself a half a day. Just don't do any dentistry. Go for lunch. Have a good long walk and swap your hard drive. Get out of being the boss and sit down and listen to your patients and just let them tell you their stories and then say, here's what I can do to help. And when you change one life, that'll bring 2 more and 4 more, and exponentially, you'll be busy. I just don't want you to get in trouble. And I'm only presenting this publicly because I know it works. So if you need a Phonetic Bite kit, I'll be glad to help you with it. If you need me to talk to your lab, I'll be glad to do it because I do it regularly. Just mention my name and most of the big labs will say, oh yeah, he's the vertical guy. But it works. And you ask any of those labs if they've ever had to rebuild my appliance? No. Next question. Ron, have you got a question?
No, I think you've done a great job.
Okay, anybody else? I know it's getting late. Apparently I talk a lot and I'm sorry that it took half an hour to get this going, but
Do your
Was it-
opening with an anterior midpoint stop ever?
pardon me?
You do that, that degree of opening with an anterior midpoint stop?
No. It's all vertical. It's just basically bite blocks over the bicuspids, 3 or 4 teeth. The reason I don't put it in the front is I want the tongue to go forward because it may be a bit constricted with the bulk of the appliance. One of the things about the nylon products when they came out was they were quite thin. They weren't as bulky. In dentistry, you need bulk for strength, so acrylic. But when I showed you the snore guard, it was quite thick because it needs it for strength. So I generally like to leave the anterior open for the tongue to be postured more forward. It would be wonderful if the lips could be competent with that vertical, and most of the time they can. But most patients will say, you know what? Don't worry about it. I'm breathing so much better. I feel so much better. A quick tip for you before you leave. My new exciting appliance is called the Avant, A-V-A-N-T, by Somnomed. You can get it out of Leamington. That's the former Patrick Strong's lab where he invented the SUAD appliance. You may have heard of that about 20 years ago, but it's a 3D printed non-nylon appliance. But the nice thing about it is the functioning parts are at the front of the mouth. The Pantera has a very big upright at the back, which can run into the coronoid process, can cause some issues in the mouth. And we're having some breakages on the connector. So when this came out, I thought this is amazing. So one little blue strap, it hooks on the back. Keep as much stuff out of the back of the mouth as you can. It's a bit thicker because it's acrylic, but it's 3D printed and it fits like a charm. AVANT, made by Somnomed out of Leamington, Ontario. I would suggest you deal directly with them as opposed to going through your own lab. It just too many hands touch it, and in the end, you want a good result.
Thanks.
Any other questions? Vipin, I see your hand. Are you asking a question? Vipin, do you have a question?
No, I was just going to say thank you, and I have to leave.
Well, would you thank your daughter very much for helping me out? I didn't know what to do.
No, she helps our Rotary Club with a Zoom platform all the time.
Oh my goodness. Who knew what Zoom meant before COVID, right? Listen, folks, I appreciate your time. In a couple of days in your email, you'll see the link, hopefully, to this if it recorded. You'll also have the PDF of the full paper. It's 15 pages long. The charts will be there for you to read.
Okay.
This is a simple technique. I know it scares you because vertical is scary, but it works. I do it all the time. Any other questions? I'll stay on until the last person wants to leave. So if you feel you have to go make dinner or charge your wine glass.
I have a question.
Okay.
Is there an appliance with a adjustable vertical?
Oh, that's a good question. With adjustable vertical. No, but I kind of invented one myself. Because the Narvel and the Pantera, you can't ask them to reline it and make 3 or 4 more millimeters. So my local lab and I invented a snap-on overlay of the pads made of a thermoplastic material. So it was kind of like a 1, 2, or 3 millimeter increase. I since found out that somebody in the States made a 3D printed version. It wasn't as good, but essentially, no, there's no vertical screw mechanisms that I'm aware of, which is why I say start big, start highest vertical, and it's real easy to reduce. I mean, I have the pleasure and the benefit of a small mini lab in my office. I've got a lab bench, I got an arbor band, and I can take 3 or 4 millimeters off in a heartbeat. I don't send it to the lab. So everything I need to do, I can do in my office. So after doing this for, I don't know, 10 years, probably under 5 times I've reduced any of the vertical at all. And it's usually in a case where I put more on than I needed to, because again, I know I can always take it off. I can't add it. But that's a good question about vertical.
And what are the signs? Oh, sorry, one other question. What are the signs that would indicate that you've opened them too much?
That's a good question. It'll go back to TMJ problems generally. So if you can document their range of motion, just the basics about watching them open and close, they don't have any clicks and pops. Typically, they'll start saying, and here's what I forgot to say after the delivery is, you start asking questions about how did it go for you? How did it go for the bed partner? Typically, the bed partner is going to say, hey, doc, you saved my marriage. She's staying with me this winter or whatever. Then I look to the patient and say, because don't ask the patient on the first week how well it worked because they won't know. So I always say, tell me when you took the appliance out, did your teeth come together okay? Oh, yeah. What do you eat for breakfast? Oh, I'm toast and eggs. We're able to chew the toast and the muffin. Oh, yeah, great. Did you have any trouble with your jaw? No. Or, oh my God, I got it out and I couldn't close and I had to bang it with my fist. That's a huge problem. Luckily, it doesn't happen much. So you ask the bed partners, what was it like? Was it quieter? Was there less tossing around? Was there less noise? If you know what apnea was, did you see less of it? If that's all going in that direction, that's anecdotal, that's great, but it's not scientific. Then you ask the patient, how did you feel when you took it out? Great, I can eat, I'm fine. Then when you get to that point, so how do you think it worked for you? Oh my God, 2 o'clock, I'm usually looking for coffee and my head's on I came home and I would cut the grass, and I go, you know, that might be a placebo effect because the first couple of days, it may not stay there, but I look for it in those 3 areas. What does the bed partner say? What's your jaw telling you? How do your teeth fit together? And finally, how's it working for you, Mr. Patient? Because it takes a while for them to really understand that they're now driving a really high performance car with high octane gas, as opposed to the cheap watery stuff they've been sputtering around on for a long time. And folks, I talk this way all the time. Doctors, nurses, medical people, they love it because I don't remember the big medical terms anyway. If you ask me how to say temporomandibular joint dysfunction 10 times in a row, I'd screw it up. So I just talk about TMJ. Did I answer your question about too much vertical?
Mhm.
And so if you have an appliance like I'm suggesting and you have a lab, you can reduce it. Maybe the best thing to do, however, is, do you know what an aqualizer is? Have you heard of the water bag, the temporary appliance?
Mhm.
You might want to send them home with one of those and have them insert it. It's a $20 item. You can buy it lots of places. If you didn't have the morning positioner, which labs will make for you, but it's an extra lab charge, just have them pop that in, have them have a shower, do whatever for a half an hour. Or the Grind No More, which you can buy at the drugstore for like $3 a piece. It's a small little silicone pad. You just want to get some action, but you don't want chew, chew, bang, bang, like a Granny Smith apple for breakfast. And closely monitor them. The most important thing is don't panic, don't throw it out. Reassure the patient that clearly what we've done is put a big pile of stuff in your mouth to get your airway open. Clearly, it's probably beyond the physiologic limit of your jaw for that night or week or month. But then say to them, if I was your tennis coach and I wanted to make you the best tennis player, I'm going to give you 1,000 balls every morning and I want you to go out and serve them against the wall of your garage, how long is it going to take before you quit? You know, professional athletes spend years getting to where they are. We're taking a patient out of the ditch who can barely breathe and put them in the top drawer. It takes some time, but don't be frightened. And please call me anytime if you got any problems, because I'll help you. That's what I'm here for. I will help you. I can't afford any of us to get in trouble, but I can certainly afford helping you find hundreds of patients, because you need to know they're out there by the thousands or the millions, depending on what population base you're talking about. I know I'm full of passion. I know I'm too excited, but it works, guys and gals. You can do it. Another question I see. Is that Paul?
Yeah, how do you need to test to see if the joint is stable, perhaps, before you do that?
Well, Paul, some of our listeners may not know that you and I have a lot of TMJ training, and you're probably hinting at, am I going to do a muscle test to check it? I didn't talk about it because I don't want people to be terrified of it. So what I said tonight was, just stand your patient up. Don't look at them in the chair. Stand them up, have them open and close. Ask them a few basic questions, measure the range of motion. If there's no popping or clicking, if they can eat fine and they're not complaining of headaches, that's a good patient to start with. And do the phonetic bite, knowing that if anything, you just have to reduce it a bit. But don't panic and don't cut too much off too soon, because if you took off too much too soon, guess who pays for the next appliance?
But how can you test if it's stable? Because I've never had one that isn't, but there must be somebody out there.
And only someone like you would look for that. I honestly, I'm busy enough doing what I am. The screening we use helps me determine whether I go forward or not. And as I said earlier, the only people that I'm concerned about are people in less than optimal dental condition or in the midst of some dental treatment or whatever. But if they function fairly normally, just remember, our profession has been talking about sleep paroxysm forever. Just remember, there's a ton of people that tell you what kind of appliance to make because the people grind. Have you ever stopped to ask yourself why they grind? Well, guess what? When you clench your teeth, you tighten your neck muscles to open up your airway so you can breathe. And I talk to patients and I say to them all the time, you know, Mrs. Smith, I am happy to be with you, but I need you to know I'm dealing with two versions of you. I'm dealing with the conscious brain that's telling me stuff and answering my questions, and we're building a rapport. But I also need you to know that in the background is your subconscious brain, the one that never goes to sleep, the one that knows what's going on all night, and the one that's probably working like crazy to keep you awake, because waking up dead is not a good option, is it, Mrs. Smith? And then you go, oh yeah, you're right. So I don't worry so much about all that, Paul. I just I find a way to tap into how they're really doing. And maybe I'm blessed to have the time to chat with people to get them to the point where they're more open and they're not intimidated, not frightened, because I'm not a scary guy. I mean, I'm just here to help you, and I'll do whatever I can. And if I can get a 75% reduction, why can't you? If you could take 10 patients out of your practice tomorrow who are either undiagnosed or non-compliant on CPAP and didn't know there was an option, and you took them aside and said, look, I think I can help you. And I have patients, I have folks like you, and I give them permission to say, I have a mentor and he'll be there to help. And I've done that. And I do it for free. I'm not on the lecture circuit. I'm not here to publish a book. I'm not here to be the next big Dr. So-and-so. I've been taught some amazing things. I've been able to help a ton of people. My staff alone and I are shocked every day about how much people have changed. If I can do it, you can do it. That's the whole point of it. I'm just an average schmuck like the rest of you. Find 10 patients, give yourself some months to do it. You'll be shocked how much better that when you look at them, they'll be more alert. Their eyes will be open. They'll be more humorous. And if you've known them for a while, you might go, well, you know, we all get kind of tired. We all get, but no, you're driving your car with the weakest, poorest gas, and you need high octane, and you didn't know where to get it. It's called air. Get it in your nose, in your lungs, in your blood cells. You'll do fine. And don't even try to convert the medical doctors who have a peripheral interest in it. They just want to pump pills at you. I'm on my soapbox, I know, but this works. Other questions? There must be somebody else. I only see 3 names. Does that mean everybody else is gone?
The problem for me is that there's so many different ways, not ways of doing it, but just, you know, AP is more important. You open it up a little, you got to advance it a little. Then you've got your aculiner. You've got all these different philosophies that all work, but I don't know when to use which.
Well, what did I talk about tonight? I said, it doesn't make any difference what appliance you choose. I said, if your patient's relatively healthy and their jaws seem to work fine and they got a decent number of teeth, all you need is a technique to record the bite registration. I don't care if you choose the pink appliance or the green one or the one with 3 screws or 10 screws. I showed you the piece of crap I made myself that still works. I actually wear it myself. It still works. So, and I've said to the, without losing your friendship, Paul, I often go to my own patients and sometimes to my doctor colleagues and say, okay, I'm going to do you the biggest favor in your life. I'm now going to turn off your thinking switch. I'm going to turn off your thinking switch, Mrs. Smith. Just wear the damn thing. Do what I tell you. It's going to work. So doctors who are overwhelmed with, oh my God, I took all these courses. You're not going to find this course anywhere. I'm just telling you this. I do it every day for all kinds of things. If it works for me and you don't have to buy anything, try it. Try it on your family. Listen, there's no family in this province who doesn't know somebody who's struggling with CPAP or has had a sleep study and doesn't want to do it. Just try it. Do it for free. I mean, you're going to have to pay for a lab bill. These are $500 and $600 and $700, but what's the price of health? What's the price of happiness? What's the price of marital harmony and kids loving dad and mom not being so crabby? Does that make sense, Paul?
Yeah.
Okay.
Makes sense what you say. It's
Turn off your thinking switch, Paul. Just do it.
that girl with the fused C3 to occiput, she's doing great.
Excuse me?
Thank you.
Oh my God.
That's just on the aqualizer.
Oh my God.
Clients.
Oh my, this, you have no idea. It warms my heart.
I can't.
Okay. It's a bit of a side discussion. The other, is it Brian? Who's in the middle there? Is it Brian? Who's,
No,
do you have any,
I'm at the top.
do you have any other questions?
Do you break them in gradually? Say the first week, you know, where you go from 2, 4, 6 hours in the night?
Excellent question. I didn't catch your first name.
Brian.
Brian, okay. You know, generally not, but if I have a patient with a reduced vertical dimension or borderline TMJ problem, or they're a bit anxious, just remember all the sleep appliances are a 2-part appliance, an upper and lower. Sometimes I'll take it apart. So take the tabs off, or they want to take the blue strap off, and simply offer them 2 separate appliances and say, you know what, let's walk before we run. How about you wear one for a couple of nights, see how it goes, and maybe wear the other one for the next few nights. I didn't get into this, but the vertical can be arbitrarily 50-50, it can be 70-30, depending on lots of things. So, if you're a bit anxious, say to the patient, let's use the one with the least vertical. It's going to open your mouth the least amount, but it's going to open your vertical more than you've ever had it open before, because you're going to give them 3 times the thickness of a night guard. Just remember that you're giving them something to chew on, so that's not forever. And then you're building up their confidence. You're the coach. Then the next night, put the other one in. Even with the 2 in and not connected on their backs, they can still slide back. But the vertical I talked about, the MV, the capital V, is there. So if they can tolerate MV, then the small a is, okay, now I'm going to put my adjustment in, whether it's a strap or whatever. Just remember, 75% of the success is the vertical right away. So if you just get them to wear 2 of them for a week or so, and then say, okay, and they'll come back and say, okay, doc, I think I'm ready for the strap. I can just tell. I was like, if you don't take offense, and if you become their coach and their partner and their friend, you got them won over. And honestly, you will not believe how many people come. I had an 81-year-old man who lost his wife this spring, married 60 some years, was diagnosed with sleep apnea somewhere, sometime, hated the CPAP, was in a bit of a spiral, came to us, and he just looked so beaten down, and we found out that he was in a bit of a depression and grieving his wife, and couldn't sleep, exhausted, wanted an appliance, and we got started, and it was going well. And he started to perk up, and he started to be more engaging and more reactive. And I for a lot of these patients, because they come from all over Southern Ontario, we follow up with teledentistry. We phone them, we talk to them. And after he got kind of comfortable, because to get him off CPAP and on oral appliance is a bit of a tricky one, he said, doc, I'm your guinea pig. I said, why? Well, I got a brother-in-law, 6 people. So if this works, and I said, oh, okay. God, that's a lot of pressure. Well, guess what? The guy's brother-in-law called today and said, so-and-so called. I'm supposed to come and see you. And so, you can't turn these people away. Treat them with kindness, treat them with passion, but most importantly, give them back their lives. And you will do that in spades all the time. I have a lot of colleagues who, I'm a bit older than most of you, are just tired of general dentistry. They're burnt out. It's such a drag. Sticking needles in and drilling holes and pulling teeth and cutting gums. I don't even have a syringe in my office. If I had to take out a baby tooth, I wouldn't know how to do it. I could, but it wouldn't be pleasant. And so I go to work every day going, wow, I wonder what I'm going to see today. Sometimes it's really tough stuff. And most of our chronic pain patients, I just tell them their story because they're too tired. I'll say, well, how many neurologists did you see? Oh, yeah, 3, no, 4. How many CAT scans? Oh, I don't know. Oh, I'm going for another one next week. How many drugs you on? Oh, 7 or 8. Who's ever looked at your jaw? Nobody. We fix their jaw and they're like, and then they start saying, can I stop taking these pills? No, I can't tell you that. I did prescribe them. I don't even know how to spell them. I don't even know what they're for. Who gave them to you? I don't know. These are zombies. They're zombies. Every practice has got them. Just start with airway. It's so simple. It's so easy to do. It's drug-free. It's totally reversible. The patient can throw it away and dog could eat it. You haven't lost anything. You haven't done anything. But you will change their lives. And maybe your own, because guess what? Most of us have the same problem. So in every household, there's a patient waiting to be treated. Is that helpful, Brian?
Yeah, it's all good. Thank you very much.
Where do you practice, by the way?
Newmarket.
Oh, you're not far away.
No, not too far. No.
Call me anytime. Call me anytime. Come and visit if you want. We have people come all the time and shadow us and get to meet the patients. Our patients love to talk.
Yeah, I think the patient interaction is very important for sure.
Oh, yeah. Yeah. That's why you take your dentist hat off and put your therapist hat on and give yourself half a day. Just give yourself half a day. Do you have an associate at all?
Yes. I
Okay,
do.
say to yourself, okay, are you the senior dentist in the office?
Yep.
How long you been a dentist?
35, I guess.
You getting tired of it?
No.
Okay.
No.
Do you want some fun doing something else that's not that hard?
Yeah, I mean, it is an option for sure. My physician actually asked me to start delivering appliances because I guess he doesn't believe in CPAP that well.
Oh my God. You have no idea the gift you got.
Mhm.
Seriously, how old is your physician? Is he about your age?
He's about my age. Yeah.
You know what? Everything I said about physicians earlier is generally true, but that doesn't mean they're all like that. There's a few good apples in a bad barrel. If he doesn't believe in CPAP, you got him right there. He can write an order for you in a heartbeat.
Yeah, true.
No, seriously, give yourself a half a day a week, once a month, twice a month. You will get so infected with what you can do. And I'm not saying you're not a good dentist, but guess what? You can open up an airway and give people a different life. Wow.
Yeah, that's very true.
But I'm not here to tell you to retire. I just have a lot of folks that I know wish they could do something other, if you know what I mean. Yeah.
Cool.
Ron, you're sitting there really quietly. Anything from you, Ron?
Oh, your enthusiasm and knowledge is inspiring. And I mean, I've been doing it for a number of years too. And I guess I've got to kind of tune up my system a little bit to go with your suggestions. But it is wonderful when people come in and they're different people.
There you go. This was an unpaid political announcement by Dr. Goldstein, who didn't show up with a matching shirt, by the way, Ron. We should have got our people to talk to each other. That's a private joke. Most of you won't get it. But I'm wearing a Kirkland shirt. This is the case.
Okay, next time I'll get in touch with you just before.
Okay, that's great. Well, folks, I don't even know if the recording's still going, but whatever we were able to record, I'll get it on the website and I'll send you the PDF of the whole presentation. And the offer stands. Call me anytime. I'm happy to help.
Terrific. Thank you very much.
Okay,
I'm gonna leave
thanks.
now.
Night, folks.